Hi everyone, my name's Yejin and I'm the Head of International for SHAWCO Health. This talk is brought to you in collaboration with Student Development of SHAWCO Health. We'll have 3 speakers presenting tonight and then we'll have a Q&A session at the end. You can submit your questions throughout the talk in the Q&A tab above. Cool, so without further ado, I'll introduce our first speaker. We've got Dr. Bronwyn Gavine. She graduated from UCT in 2015 with first-class honors. She was the clinic head for SHAWCO's Simthandile clinic and vice president of the UCT SurgsoC during her years at UCT. After completing her internship and community service, she was awarded the prestigious Rhodes Scholarship and undertook a master's in neuroscience before starting her PhD in Clinical Neurosciences at the University of Oxford. Her main research focuses on brain plasticity and techniques to improve motor recovery after brain injury. So, Bronwyn, over to you.
Great, thank you so much for having me. It's such an honor to be tentatively back at UCT, even though it's not in person, and hopefully one day soon it will be in person. And thanks so much to the SHAWCO team for organizing this. I really appreciate it. So as you all know, this forms part of the What Next series, and I'll be sharing a little bit about what I did next, which was after my ComServe, I paused my clinical practice and I went into full-time research. And I'm currently doing my PhD at the University of Oxford. And so I'll be sharing about how I did that, but also some other avenues that you can explore and hopefully some helpful advice as we go along. That's mainly what I'll be covering. So to start off, a little bit about me. I grew up in a very small town called Welkom in the middle of the Free State. It is hot in summer, very cold in winter, and very flat and not very beautiful. That is pretty much the best photo I could find of it on Google. And I'll be sharing a lot of embarrassing photos of me over the time just to keep things entertaining. So this is me at 5 years old as I started school, and I went to the same school for 13 years, right from preschool to matric. I graduated from UCT and as I said, am now furthering my studies. I'll just be talking to you basically about my time from matric to now. So starting off, this is my wonderful matric class that we all finished together. We were 13 in our grade and 9 of us had been together since we were in preschool. So we were a very tight-knit bunch and we had been together through all the various phases of life. And we had a wonderful experience in matric, but it meant that when I came to UCT, I was pretty overwhelmed by the fact that I had 200 people in my class, 400 people in Rochester residence where I was living, and that combined with the heavy workload of chemistry and physics in the first term, it just made me feel very overwhelmed. And so I actually didn't take on any extracurricular activities for most of my first year of med school. But eventually in my second semester, after a lot of begging and pleading from a few of my friends, I went to my first SHAWCO clinic, which was Simthandile clinic on a Monday night. And that was really what started opening my eyes to all the unique opportunities that we had and really helped me to get more and more involved. So throughout med school, I got progressively more social and more involved, which involved creating a great dissection group, which is the photo on the right, who really got me through the long dissection mornings in second year, and also getting more involved in SHAWCO until finally reaching that pinnacle of the December graduation in 2015. And the next up for me was moving to East London to do internship at the East London Hospital Complex, which is combined with Frey Hospital and Cecilia Makawane Hospital, which was a fantastic time, a really good balance between clinical exposure, fairly good supervision mostly, and probably about as good a work-life balance as you can get when you're working 80 to 120 hours overtime every month. And perhaps one of the highlights of the first month was figuring out that I was also not just Dr. Gavine, but Dr. Gavin, Dr. Gore, Dr. Gavir, and Dr. Gore, and all the other alterations of how people spell my name, which for a long time I just had no idea who they thought they were referring their patients to. And apart from just doing internship, we had a great time exploring all the various parts of the beautiful Eastern Cape. And after that, I moved to Bloemfontein. I was very lucky. I got my second choice for ComServe and did community service at 3 Mil in Bloemfontein. I worked in a mixture of family medicine, casualty, and general surgery, and was very grateful to have fairly good surgical experience. I got to host one of my friends who did her elective there and actually gave the SHAWCO talk last week for Mtembeni. And we also had an amazing consultant who taught me so much during that year. Other perks included a superbly arranged set of scrub array in theatre, which was by far the best I'd ever seen in any government hospital. And I was very pleased that there was always the size you needed, which I had never come across before that. And I've got a lot of orthopedics exposure, which I felt very ill prepared for, but really enjoyed it. And after ComServe, I moved to Oxford. I did my master's in neuroscience, which is a 1-year taught master's, and it consisted of 1 term of lectures and practicals with an exam and 2 terms of optional courses, so you got to pick what you were interested in, and then 2 projects that culminated in 2 master's theses. And after that, I decided that I didn't quite feel like I had learned as much as I wanted to and felt that there was a lot more to do. So I progressed on to my PhD, which in Oxford is called a DPhil. It has been a little bit topsy-turvy because of COVID, but mostly my day-to-day has consisted of reviewing literature, developing research questions, and figuring out what types of experimental procedures could be designed to probe these questions, applying for multitudes of ethics for various projects, and then at the moment, my favorite part, which is running the projects, collecting the data, analyzing the data, with a little bit of attending journal clubs and learning new skills in between. And I'm very privileged to work in a unit that does world-class research in MR imaging, using all sorts of techniques, which is why I especially wanted to come to Oxford, and also using a technique which is what I use in the center middle picture, which is called non-invasive brain stimulation, which is what a lot of my experiments are designed around. And life in Oxford has been really good. It has involved a lot of exploration of self, and it's been a breath of fresh air to sleep in my own bed every night and not be called out, and explore new places and make friends and have time to explore academic interests, not just to focus on studying for exams. So I wanted to share some of the tips that I thought are useful for anyone that's considering any kind of career in academia, whether that's further study now or further study later, or just being involved in ongoing research during your clinical course. So I would strongly recommend that while you're at university, you be as proactive as you can and try new things. And this can involve getting involved in different societies and doing outreach and getting involved in research. But alongside this, make sure that you don't get bogged down by trying to fill out and doing too many things, and just make sure that you focus on creating lasting friendships. I would also strongly recommend that you appreciate the wealth of clinicians that we are taught by at UCT. I called many professors during my intern and ComServe years at UCT asking for help with complicated patients, and it really opened my eyes to how much knowledge and expertise we have right at our fingertips. And so if there is someone that you know that is doing something that you find really interesting or that you'd like to learn more about, I would always strongly recommend that you get in touch with our senior clinicians, try to get to know them, spend extra time in the clinics that you're interested in, ask them if they have research going on, and really try and get to know at least a few mentors in the clinical sphere, not just to expand your knowledge now and to help you figure out what you want to do later on and see what you're interested in, but it also helps to know people personally if you ever need references, especially academic references. So for me, what this looked like was being involved in societies. So I joined SurgSoc actually quite a lot after I joined SHAWCO. I was head of education when we ran the first international conference for student surgical societies in Cape Town, which was a phenomenal experience, and then progressed on to vice president in my final year. And as a result of that, we got to travel to Brisbane in Australia for the second International Association of Student Surgical Societies conference, and really made fantastic friendships and learned so much about organizing events and figuring out how to get sponsorships for large amounts of money and organizing speakers. Yes, it was a really valuable learning curve being involved in that process. And then, of course, my first love, SHAWCO. So I went to SHAWCO clinics throughout all 6 years. Loved my time doing SHAWCO Rural, where we went to Vredenburg in my third year, and spent countless hours in our beautiful Simthandile clinic with our beautiful clinic open Noli. And it gave me invaluable clinical knowledge, but also lasting friendships. The next thing that I was involved with that helped me a lot later on was picking an SSM project that I was really interested in, and picking really good supervisors, which I didn't know in advance, but I worked with Ursula Rawink and Prof. Gaji, and they are excellent scientists, excellent clinicians, and taught me so much about the value of research in shaping clinical practice. And as a result of that, I was very privileged to be able to present at an international conference and really get very involved. So I spent a lot of time with them throughout the rest of my clinical years, continuing with that. I was also very fortunate to do a couple of really fun electives. So I went to Zitalele Hospital in my third year as an RSM placement, and then again in my fifth year with my clinical partner Nathan, and did an optional elective at Oxford in neurosurgery in my fifth year December holiday. And all of those really helped to introduce me to different types of clinical practice and also expand and think about what I wanted to do next. And then I do just want to give a personal shout out too. So I was really lucky to have an incredible clinical partner, Nathan, who constantly inspired me to work harder and to aim to be the best that I could be. And he had this incredible hunger for knowledge, and we had really good skills that complemented each other, and he made 24-hour calls so much more fun and made studying for exams so much better. And so I would strongly recommend that if you're going into the clinical years, pick your clinical partner really well, because they can make the time so enjoyable. And lastly, to pick friendships, invest in people. This is a photo that I took in my first year in Oxford. And all of those people in the photo graduated from UCT. They all graduated from the Faculty of Health Science. They are mostly doctors, but Kaya is a physiotherapist, and they've all done further study at the University of Oxford. And they're all people that I knew through SHAWCO and through SurgSoc. So 3 of our committee members from my second last year of SurgSoc came to Oxford. And we all knew each other before we came here, and that's made the world of difference in having friendly faces. So my advice, make sure that you consider why you're thinking about research and why you're thinking about academia. Think about the timing in relation to, do you want to do it before internship and ComServe or after internship and ComServe, or do you want to do it before specialization or after specialization? Personally, I would strongly recommend that you complete internship and ComServe before taking any time out in your clinical practice, because the rules change fairly frequently. It's very difficult to know if you would be able to get back into practice without doing your internship and ComServe, and we all know how tricky it can be to get those places too. So I would strongly recommend getting those done and having that safety net, because it means you can always come back to South Africa and work. The timing pre and post specialization is much more contentious. Think about why you think this degree that you're thinking of doing is useful, and think about where you want to study and what the implications of that are, specifically how to cover fees, because international fees are very expensive. My fees are £29,000 a year, which is roughly 600,000 rand, which I'm very grateful is fully funded by my scholarship, but that amount is not really doable off the salary. And be mindful of maintaining clinical practice. It's not an easy thing to just be a doctor in South Africa and come across to the UK and be a doctor. You have to write exams, they're quite expensive, it takes a long time. And I wish I had been more mindful of maintaining clinical practice before I started. And I wish that I'd made more of an effort, because I've only just been able to start working clinically again after being here for almost 3 years. So that's my advice for that. There is a long list of scholarships, but these are some that I can recommend that you look into if you are interested in studying overseas. There are some that are specifically university-based. There are some that are specifically based on geographic region, and then there's some that are open to anyone to study anywhere. And a quick Google search of any of these will show you that they're really good, but they do also have restrictions. So for example, the scholarship that I'm on has an age restriction, which is adjusted for doctors, but still means you have to sort of get in just at the end of ComServe, otherwise you'll be too old. And don't discount other really good options. So South Africa is moving more towards being able to offer clinicians taught masters or very good PhD programs. There is a lot of National Research Foundation funding. There are also university-specific or departmental-specific funding available. You can also do research rotations. Some of my friends from med school are doing research jobs at the moment. And there's always the option of doing a post-specialization fellowship overseas too, which is what many of our consultants at Pritiski have done. So to summarize, there's no harm at looking in options early. I would advise you to get an idea of what you want to do, what it would involve, and how early you have to start the process. Do it sooner rather than later. Make sure that you are passionate about what you want to do. Don't just do it for your CV. Be intentional about friendships and developing good relationships with mentors. And remember that there are loads of good options around there, including plenty of funding. You just have to know where to look or who to ask. So thank you very much. Really appreciate your time. I hope that was helpful, and I will hand back now.
Thank you so much, Bronwyn, for providing such insight into your life at UCT and the daunting first year experience I think all of us can relate to. It was amazing to see life through your pictures, and thank you so much for your insightful tips. I think we can all feel overwhelmed at times when it comes to our career path. So it's helpful to hear your advice and see how everything you've done and still do is so influential to your life. I think we all have quite a lot to think about. So thank you. On to our next speaker. So Dr. Carol Lewis graduated in UCT in 2003. She did her internship in RK Khan in Durban and community service in Settlers Hospital in Grahamstown. Then she went to work on cruise ships for 6 years, from 2007 until 2012, living the life of luxury. In 2013, she joined the Emergency Medicine Registrar program in KZN. She finished her reg time at the end of 2016, and in 2017 joined Helen Joseph Hospital in Joburg as an ED consultant. She has now been in Malta since January of this year, heading up the emergency departments of the private medical hospital group on the island. Over to you.
Okay, fantastic. Thank you so much, and thank you very much for having me on to chat with everyone. So, as you mentioned, my name is Carol. I'm an emergency medicine specialist. And what I thought about doing today is just telling you a little bit about how I landed up where I am at the moment. So, as you mentioned, I graduated from UCT in 2003. I really like what Bronwyn said about picking your friends intentionally. So I made some fantastic friends when I was in UCT. And I don't know if you're familiar with Siobhan Gordon, who is in the Obs and Gynae department. She was one of my very good friends all throughout undergrad. And having really good friends stands you in excellent stead going forward. In contrast to Bronwyn, who is head of Surgical Society, I was head of Wine Tasting Society at UCT. So maybe not quite so much of an academic endeavor in that regard. And when I finished in UCT, I went on and did internship in Durban. So Durban is an amazing city. It's got sunshine, it's got beaches, it's got the Sharks rugby team, very important, highly recommended as a rugby team to support. It's got samosas, it's got bunny chow. It is an amazing part of the world. So I really, really enjoyed doing my internship there. And after internship, I then thought that I would go back to the town that I grew up in. So this is Grahamstown, now called Mkanda. And I thought at the time that applying for ComServe posts is always a bit tricky. You want to apply somewhere that has got decent supervision, a decent hospital. and ideally somewhere where you're actually going to get a post. So you want to pick somewhere that not too many other people want to go to, which is why I thought the Eastern Cape might be a good idea. Really enjoyed the year that I had there, and the advantage was that my family still lived in Grahamstown. So although I lived on hospital property, I could go home for Sunday lunch, I could take my laundry home to my family, which was a major advantage. So ComServe in Grahamstown, and then I went back through to Durban for my medical MO year, and then I was left with a bit of a choice. What do you do after that? And you'll find when you do internship and community service, if you are half decent at anything, everyone wants you to specialize, and they want you to specialize really early. And you've got a choice then. Do you do what everyone seems to be doing, and that's jump straight into a speciality? Or do you try and do something a little bit different? And the problem is that if you commit to a speciality early, that's it, that's your career. So you're going to spend 4 years doing a speciality, and then you're a consultant, and then you have a job, and you haven't really explored any other options. And I think choosing that choice of what to specialize in is really tricky. So if you ask people, why have you picked a certain speciality? Some people, and I think pediatricians are the prime example of this, they love their patients. Anytime you see a pediatrician, they think babies are fantastic. I strongly dislike babies, but all pediatricians tend to pick their speciality because they love patients. Some people pick it for a really good work-life balance. So you've got dedicated hours that you're at the hospital, really good time being at home with your family. So I'm thinking dermatology, radiology, really good options for a good work-life balance. I'm an emergency medicine specialist, so we like cool toys. So if you're interested in the latest ventilators and the latest ultrasound machines, maybe that's a good option. I was chatting with a colleague of mine the other day, and I asked him why he'd specialized in anesthetics. And he said, in Malta, it's crazy hot. And when he was choosing a speciality, the only place in the entire hospital that was air conditioned was theatre. So he decided to specialize in anesthetics because he decided he never ever wanted to leave theatre. And I thought that was a crazy reason for picking a speciality. I mean, it's clearly worked for him, he's quite happy, but if you look at all the different reasons that people pick a speciality, there are so many different reasons, and I'm not sure that all of them are particularly good reasons. So maybe it's an option to consider doing something slightly different. So I thought, let me go and work on cruise ships for a couple of years. And my plan was to do this for a year, maybe 2 years, and just do something different. Try and decide what on earth I wanted to specialize in while I was cruising around the world on a luxury cruise ship. So cruise ships usually have anywhere between 2,000 and 5,000 passengers, if you're looking at the really big ones, and usually then about half that same amount again in crew. So if you've got 2,500 passengers, you'll have 1,200 crew members. And obviously, the more passengers, the more crew members you've got. And then typically you'll have a medical team of 2 doctors, 2 or 3 nurses, and 2 or 3 paramedics. So it's a really interesting setup, and this is what you see on board cruise ships, so they can do a hell of a lot. On the left-hand side, I've got pictures of the procedure rooms. So you're able to suture, you can plaster, you can do mini procedures on board. There's a slit lamp in the corner over there. The middle picture is one of the wards, so just a general ward. I've got a full ICU down the bottom with ventilators, defibs, monitoring. I've got radiology set up. What I haven't got a good picture of is the lab facilities. So we would typically have point of care testing for a full blood count, kidney functions, liver functions, cardiac functions. We could cross-match blood on board. So I thought this was fantastic. If, for instance, you had an upper GI bleed and you needed to give a blood transfusion, and we didn't carry blood on board, but you could type your patient's blood and find out that your patient is, for instance, A positive, and you would put out a loudspeaker announcement over the tannoy for the ship and ask for A positive blood donors, and you would then venisect your passengers who are A positive. You test their blood to make sure it's the right group, screen for HIV and hepatitis, and then transfuse whole blood. So you venisect a bag, walk next door, hang it up in the next door room, and off you go. That's your whole blood. When I first got to ships, I honestly expected to be treating motion sickness. I had no idea why the medical centers were as well set up as they are. Because if you look at all the brochures for cruise ships, you see these lovely, young, fit, healthy looking people sailing off into the sunset. It looks absolutely magical. And to be honest, it couldn't be further from the truth. So what we tended to find on board was folks who would often cruise when they're retired, because now they have a little bit more time and maybe a bit more money, but often it was a bucket list. So you are elderly, maybe you've been diagnosed with terminal something, and you want to see Alaska, or you want to cruise through the Panama Canal. So we would have these folks in their 80s or 90s coming on board with their wheelchairs or their mobility scooters, with their CPAP under their arm and their bag packed full of medications. They did not look young and fit and healthy. And we would have to try and keep these folks alive and going for the duration of their cruise. So we were kept super, super busy. And this is a typical setup of the type of ICU that we would have on board the ships. So what type of patients did we end up seeing? Well, a little bit of everything. So if we were treating crew members, it would often be slips, trips and falls. The chefs cut themselves all the time. I don't know how chefs managed to not be a little bit better with knives, so we did lots of suturing. IVs, dehydration, gastro, people who are out in the sun, so heat stroke, pneumonias. And if it was trauma, it tended to be minor old folks trauma. So it would be a Colles fracture of the wrist or a fractured neck or femur, but quite a varied practice and actually very similar to what you'd find in the average emergency department on land. But there are a couple of things that are a little bit different about cruise ship medicine. And one of the major differences is that if your patient is super duper sick, you're stuck with them on board the ship, or you've got to get them off. You don't have the option of transferring them to the tertiary hospital down the road. You've got to make a plan to get them off the ship. And you could do that either via tender boat or via helicopter. Oops, wrong way, or via helicopter. So this would be an example, and we had a lovely patient who'd come on board at 32 weeks pregnant. Now, you're not supposed to be on board the ship if you are pregnant, and I don't know how she got up the gangway with no one noticing that she had a really big belly, and she went into preterm labor at 32 weeks. Now, the concern from our side was that if she delivered a baby on board, I could probably deliver a baby, haven't for a long time, but I could make a plan. But if she had a preemie baby and if the baby was sick, we'd be really stuck. So that patient, we ended up disembarking on a little tender boat. We pulled in close enough to Cabo San Lucas in Mexico that we could get her off and through to hospital. And she delivered a healthy baby in the hospital. But that would be the type of patient that we would struggle to manage on board. This patient was a patient that we ended up disembarking off the coast of Japan. He was really interesting. He was a gentleman in his 60s who had been walking around the ship, and he had had a bit of a syncopal episode and collapsed and hit his head. And then he regained consciousness, and we brought him down to the medical center. And on his ECG, he had an ST segment elevation MI. Now, the problem is on board the ship, you'd obviously don't have options for a cath lab, so you want to thrombolize him, but he'd had a syncopal episode, fallen backwards and hit his head, and he had a massive hematoma on the back of his head. And he'd had a loss of consciousness, so we were really worried about thrombolizing someone who may or may not have had a head injury. So we ended up disembarking him by helicopter to get him through to Japan so that they could CT scan his brain. He didn't, in fact, have an intracranial bleed. And they then decided that seeing as he was in a hospital with access to a cath lab, they'd take him for cath. And he did really well. But those are the type of patients that you would see on board ships that exceed what you could offer. But really interesting patients. And then on a personal level, I enjoyed the fact that I was living in the lap of luxury. So this is a grand atrium on board the cruise ships. And when you finish your morning clinic, I'd go and sit there and have my cappuccino. Like it is really, really glorious. And then you've got this opportunity to travel. I absolutely love traveling and have had the opportunity to go more or less everywhere. So this is Mykonos, which is one of the Greek islands. Fantastic sunshine. This is Istanbul and the Blue Mosque. Amazing center for culture and heritage and fantastic shopping in the Grand Bazaar. If you're ever interested in a Turkish carpet, this is the place to go. And then I've had a chance to see some amazing pieces of history around the world. So the Acropolis in Athens, the Library of Ephesians in Ephesus in Kusadasi. So this is from kind of biblical type era. And then the Trevi Fountain in Rome, this is Petra in Jordan, and it's not all old ruins. I've been to Hollywood, had to find a star for a decent looking gent on Hollywood Boulevard. And I met some amazing people and did some amazing things. So this was one of our spinning classes. And this was off the coast of Mexico. We decided instead of being in the gym, we take our spinning class up to the top deck under fantastic sunshine and really make the most of the fact that we were in Mexico. It was a really good place to be. This is Sydney Harbour Bridge. And this is somewhere in the South Pacific. To be honest, I can't remember which island it is. And I realize that that's such a spoiled thing to say. I've really had the opportunity to travel just about everywhere, including Bora Bora and Tahiti. But after 6 years at sea, I realized that my friends had all specialized. And I was still a medical officer, drinking pina coladas, sailing around the world, living a fantastic life. But you get to a stage where you realize that your career isn't progressing. And I think you get to the stage where you know what you don't know. So when you start off as a junior doctor, you think that you know absolutely everything. And then the more patients you end up seeing and treating, the more you realize that there are things that you don't know and that you could do better. So I thought that it was time to specialize. So I applied for a post as a registrar in KZN. I interviewed. I thought I was interviewing for a post in Durban. And I got my acceptance letter saying, congratulations, you've got into the registrar program for emergency medicine in KZN, and you're going to Ngwelezan. So I pulled out a map and I looked out where Ngwelezan was. And I phoned up my mother in a bit of a panic saying, Mom, I'm being sent to northern KZN. This is nowhere near Durban. And I remember driving in to have a look in December before I started in January and feeling like I was driving into Mordor, because you drive in and it's crazy hot. It was 38 degrees, crazy humidity. And it was a definite change from working in the middle of luxury on board cruise ships. But I settled in really quickly and I really enjoyed my registrar time. So I had 1 year in Ngwelezan, and during that time we did a lot of air rescue services. So Ngwelezan's the main drainage hospital for all of northern KZN. So once a week we'd be out doing flying medicine. So based at the Richards Bay Air Base, and we'd be flying up to Manguzi or Msileni and picking up patients and bringing them back through to Ngwelezan. And obviously on the way back, you've got your patient in the helicopter with you, but on the way up, you don't, and you're going all the way up the coastline. So we would be whale watching along the coastline as we went up. Or if we were going inland to Bethesda Hospital, we would fly over Hlitlui Umfolozi, and you basically be game watching. Like, oh, look, herd of elephant on the left, herd of rhino on the right. It was fantastic. So really worthwhile doing. So 1 year at Ngwelezan, and then off to Edendale Hospital for the next 3 years. And at the end of that, graduated as an emergency medicine consultant. I had a bit of an interest, though, in what did people do when they left cruise ships? Because I found that when I started my registrar training, there was a bit of a misconception that that time that I'd spent on cruise ships maybe wasn't as well spent academically as many other people. So this is an article that I published a couple of years ago. And what I did was ask people who had been on cruise ships, what did they do after cruise ships? And what it showed is that there are a lot of people who have gone onto cruise ships, taken the time to work out what to specialize in, and come back and joined a registrar program somewhere. So that might not necessarily be in South Africa, that might be overseas. It might not necessarily be emergency medicine, that's my interest. But the vast majority of people who've gone off onto cruise ships don't do that forever. There are a handful of people who do that long term, but for most people, it's a 2 to 5 year plan. You get to earn a little bit of foreign currency, which is great. You travel, you grow as a person, and then you come back and you end up specializing. So interestingly, from UCT at the last set of specialist exams, you had, I need to remember this, 2 people that were on board cruise ships with me, Dave Kluti and Kamla Nakambaran, that you might know from Gear, who've just qualified as specialists. So going to cruise ships definitely isn't a bad thing in terms of career progression. Obviously planning it correctly, making sure that you do come back at some stage. After that, I then went on to Helen Joseph Hospital in Joburg. And this was honestly the best photograph that I could find of Helen Joseph, with the ominous clouds in the background. And I say ominous because I think this was taken about 5 o'clock in the morning. It's never quiet. It's constantly chaos. It's a really high-paced environment and with good clinical medicine. I love the team. I enjoyed the work. But after a couple of years, I found that just the pace of it, so this would be a typical New Year's Eve, absolute mayhem and chaos. The pace of it is actually quite difficult to manage because although I love the team, I love practicing medicine, after 3 or 4 years of relentless end of month weekends looking like this, I started to not like my patients that much. I love my team, but I'm not too sure that I really liked my patients. And I think often people get to that stage where they get a little bit disillusioned, and then it's time to consider a change. So I thought, well, what do I do next? Because if you ever get to the stage where you're not loving what you do, then you need a bit of a change to make sure that you can then build up the strength to carry on and do what you continue doing. So I thought, let me move somewhere slightly different. And my husband and I chatted about this, and we decided that we would make the move to Europe because our families have all immigrated and are all in Europe. But my husband said he will not, over his dead body, live in a cold, wet, miserable country. So that counted out the UK and Ireland. So we decided that we would go and live in Malta. So I hear you asking, where on earth is Malta? Malta is a tiny little island. If you go down to the tip of Italy and you go a little bit further south, Malta is this tiny little island in the middle of nowhere. It's part of the EU. It's an English-speaking country. They drive on the correct side of the road. They've got a good high quality of medicine. The whole country is 500,000 people. So if you think that Joburg is roughly 5 million, this was a major change for us to be moving somewhere a little bit smaller. But it meant that I had a slightly better work-life balance. So this is the view that I now wake up and look out to. My husband's brother and sister-in-law own a kayaking company. So this is what we do on our weekends, off kayaking around Malta and the Northern Island Gozo. This is the main promenade area. It is beautiful. And we've had a chance just to get out, reconnect a little bit, fall in love with medicine once again, which I think is really, really important. We immigrated with our pets, so we've taken the entire menagerie with us. So this is little Wellington and Higgins, and this is a typical sort of sunset that we have from Malta. So not a bad place to be in a world. So if I was to sum up, the important things that I wanted to emphasize are that it's okay to take the scenic route to specializing. You don't need to specialize straight after ComServe. It's all right to try and work out where your interest lies, what you want to do, and make quite sure that the speciality you've chosen is the speciality for you. And it's okay to not specialize. If you want to end up being a GP, that's absolutely fine. There's so much pressure to specialize, and there are a lot of other options that don't include specializing. It's okay to travel and see the world, and it's okay to work in a different country. I found a lot of people think that you are leaving South Africa when you go to work in a different country, and I don't think that that's the case. Sometimes you need a little bit of a break to recharge your batteries and see what medicine's like elsewhere, because any experience that you have, be it on ships or in a different country, only increases the type of medicine that you can offer to your patients. And when you're ready, then it's okay to come back to South Africa. So that's it from me. Let me stop sharing and let me hand back over. Here we go.
Thank you so much, Carol, for giving us your honest opinion on how important it is that we take time to explore our options. It was great to hear the differences between specialties and some interesting reasons to choose them. Thank you for giving us true insight into the advantages and disadvantages of being a doctor at sea, and for sharing all of your incredible stories. I think it's safe to say that many of us are jealous of your life's experiences. Thank you. So on to the next speaker. So TJ Melherber graduated with a BSc Physiotherapy from UCT in 1997. She then went on to become a ballet teacher as well as a performer in 1998. In 2000, she got a Pilates qualification, and in 2010, she got a degree in sports physiotherapy and has been working since. She works with a lot of individual athletes, such as Protea cricketers, WP rugby players, and SA water polo players. She worked and travelled with the Nashua Cobras for 12 years to Australia and worked as India's national cricket team's assistant physio. She was also an assistant physio for the SA Ladies Hockey, the English Ladies Sevens rugby team, the Cape Town City Ballet team, and many others. She loves her job and the people she gets to help and meet along the way. Thank you.
Again, got you. Okay, how's it, everybody? Yeah, those two doctors that spoke ahead of me are complete wonderful achievers. The irony is, when I got asked to give you this chat, I had to sit down because it's been 21 years since that I've been practicing, and 21 years I had to think, jeepers, how did I end up where I ended up? And it actually probably goes back to when I was in grade 9, I think, standard 7 at the time. That's how old I am. And I was performing as a ballerina then, and we had a kinesiologist come over and present a workshop. And I was really fascinated by all the terminology and the anatomy and everything that this lady was talking about and demonstrating with us. And to be honest with you, if I had to go back then, I said to my parents, I'm going to be a kinesiologist. They then obviously were very worried about getting into a matric correct subject line, and so it was off to the psychologist, the industrial psychologist, to say, really, is this what my daughter should be doing? And so what I did was I went through all the processes, and again, they came up medicine, physio, OT, nursing, and they went through everything. So I was definitely along that line. It was correct. But kinesiology at the time, I'm standing to be corrected now, you could only study in the States, and it had to be a postgrad degree. So I had to come up with a plan in the interim. I applied for physiotherapy and I was turned down by UCT. I was turned down by Stellenbosch. So I had to come up with another plan. And in fact, I got into medicine at UCT eventually, but we didn't even have a family doctor. So to now commit at that time 7 years to medicine, was quite a hard thought process for me, because I'd be taking somebody's place that desperately medicine was what they wanted to do, and just take the opening at UCT because that's where I could get in. And instead, I sat with, at the time, it was Mr. J.P. van Niekerk, who was the head, he was the dean of the medical faculty, and he suggested, go and do any university degree, anything, but as long as you came back with firsts, and then reapply to physiotherapy. So that was where I was. And I said to him, well, where do you have openings in the medical faculty? Because I still wanted to stay within the medical fraternity. And he said to me, well, there are gaps in nursing, but you'll have to chat to the professor. So literally from the dean's office, I walked up the road and I went into the professor of nursing, because I don't think nursing's done at UCT anymore. And I said, listen, Professor, I don't want to be a nurse, but I would like to do a medical degree, not medicine, and try and get firsts and try and get into physiotherapy. So to cut a long story short, I had to do a year of nursing. I sat outside Professor Bauerbank, who was the professor and head of physiotherapy at the time, outside her office at 6:30 every morning, just to make sure that she remembered who I was and that I would be applying, and that she had said no the first time, but she wasn't allowed to say no the second time. And at the end of that year, I reapplied and I got into physiotherapy at UCT, and yet turned away again at Stellenbosch. So don't let disappointments along the way, stop you in your tracks. Stick with your passions and stick with your gut and follow those. And I did UCT physiotherapy from 1994 to 1997. And then it was a bit like, well, what now? Because I had been performing all along the way, and I'm kind of one of those people where, same as going to university, I didn't want to leave saying I had something, like I had a BA or I had a BCom, or I needed to leave saying I was a something. And so with my dancing career, I didn't want to say, well, I got to intermediate or I got into advanced. I wanted to finish with having done a teaching degree. So in 1998, I did my dancing final performers. And I then did my international dance teachers in the Chiketi method. And then I went overseas to the UK, and I did that traditional, in my time, that was a traditional like 2-year work holiday visa. I went over, again, got stopped to work as a physiotherapist because my registration didn't go through, and there were complications as to, you know, certain criteria that needed to be met from what we had done in South Africa as qualifying as a physiotherapist and what was required in the UK, because the way that they're qualified is vastly different, and then there's a hierarchy system that happens in the UK. And so where did I fit in that? And eventually it came through, but in the interim, I performed in London West End, and I danced and I taught. And then I decided that I'd had enough of the UK, and I also never stayed in one place in the UK. I did live in Scotland, I lived in Glasgow, I worked at Airdrie at Monklands Hospital, I worked in the Diana Princess of Wales Hospital in Grimsby, and they're typically places that I can tell you now, I'm sure that Bronwyn will agree, most people say, you know, what the hell were you doing in those places? Like, no one even wants to live there, let alone choose to go and work there. But my idea was to try and absorb the culture, as Carolyn said, try and travel a bit within the UK. So I never took a locum longer than 3 months. And I plotted my little journey around the UK, including Scotland. I met people that worked within Scotland Rugby. I worked a little bit with the South African, the Springboks at the time when they were touring over there. And I think that both Bronwyn and Carolyn have definitely brought up the importance of connecting. Don't get so bogged down in your goal and your drive and put your head down in the books and forget all those wonderful personalities that you're meeting along the way, because you just never, ever, ever know when that connection comes up again. And in 21 years, I can tell you I'm still connected with those people, ironically, all over the place, and we still consult between one another. We've still referred patients to one another, and so the journey is still a continuum. Anyway, after that, I came back. So in 2000, I came back, and while I was dancing exposed me to Pilates. The company I was dancing for, we had to do so much Pilates, and I thought this is quite an interesting method. I quite like the movement behind it, and the reason for doing some of these things. I think it's going to complement my physio. So I came back and finished the Pilates degree here in South Africa, but through Rael Rabinovitz, who's actually an American Pilates instructor, and written quite a lot of books on Pilates. So you might have come across his name for those physios that are out there. And I did my Pilates qualification, and also at that moment in time, one of those connections that I'd made as a student, who gave me a working opportunity during a holiday vac, was to work with the World Longboard, Helen Milson. She's a physio that's worked with stormers. I'm sure those that have done any sort of physio courses, her name comes up endlessly over and over again. She's really paved the way for women in sports, and so she's one of my greatest mentors. She then let me work with the World Longboards, and when I came back from the UK, she then was moving out of the post with Western Province Cricket, and she had to give 4 or 5 names forward to Western Province Cricket, and unbeknownst to me, my name was one of them, and we went through that process, and that's how I landed with Western Province Cricket. And I worked with Western Province Cricket, which then became Western Province Boerland, that's then National Cape Cobras, National Mobile Cape Cobras, and I'm sure those that do follow the sport, you will see that we've changed names endlessly. I worked with them for 12 years, where I had the wonderful opportunity of traveling in 2005 to Sri Lanka for an under-19 World Cup. And then I traveled with the Cape Cobras to their Champions League in India. I've managed to go to Australia with the Proteas B team. I've managed to even do a 2020 World Cup with the ladies. Danae van Niekerk was 16 at the time. She's now our present ladies captain, still in contact with all of them as well. I went to a World Cup with them in 2008. I even managed to get myself banned. I don't know if any of you do watch cricket, but there's something called the IPL. It's a cricket league in India, and India run cricket basically internationally. The money for cricket is all in India. And it became a bun fight between a gentleman that was on the BCCI, he does the IPL, and a gentleman that's not on the BCCI board, and he created the CPL. And those of us that went and got employed by the CPL the ICL, got ourselves banned because it wasn't sanctioned by the BCCI. So that was an interesting phenomenon to go through, because now we were banned from working anywhere in the world because we had done this league. And then again, one of those connections that had come up along the way said, won't you just help me out with Ireland men's team? So I went and joined Ireland's men's team. But the sneaky thing was that because the ICC never questioned me being at that event, and I did an ICC event, there was no ways that they could come back and then unban me. So I did this event with no one saying a thing. And then the Cobras were allowed to employ me again. So I went back to them and did their tour to India. And that's ICL that I did in India. I was with the Hyderabad Heroes. I spent 4 months living in India and traveling around India. So again, I've still got connections there from those days, because I was the only girl. The Indian culture that, typically women in men's change room is culturally debatable. So we had to make a plan. And I was the only woman, I was the only South African. Most of them are Australian, New Zealand, or English. And so that was a great opportunity. But again, networking as you go, because I still work and refer between Australia and India and the UK. I still work with all those trainers, S&Cs as they call them, biokinesists here, the doctors and the physiotherapists. So, I mean, it's been amazing, the journey that I have been on. I own my own practice now in Cape Town. I've been with Villages Rugby Club as well, which is a winter component. That also happened when I came back from the UK. It was like, well, now what? And Villages were looking for a physio, so I based myself there. And I've literally just been working with all sorts of things. I've done the England Sevens team. I've done the hockey, as it was mentioned. And I just had these most wonderful opportunities where I've grabbed them with open hands. And the networking from that and the offspin from all of that has been amazing. And the irony, I'm known as a rehab physio. I've never had to do the kinesiology. I've never even ventured to go and try and do it, because I sit doing movement patterns and pre-rehab, trying to get people not injured in the first place, and post-rehab, be it orthopedic, or I have 1 or 2 neurological patients, but movement is the same. I can't reiterate exactly what Carolyn and Bronwyn have both said, is that please make sure that you're passion-driven. It's going to be very hard for you if you're hating what you do. Be passion-driven. With that, connect with the people that are around you on your journey. Don't put yourself in a box. At one stage, I was terrified, because I was like, oh, TJ, the cricket physio. I'm not a cricket physio. I'm actually a ballerina, and I have also worked with the Cape Town City Ballet, and I've done this, and I might be a bit like a box of chocolates with all different flavors and all different colors and all that sort of thing. But I get to do it. Doesn't matter who the athlete is and in which team it is. The evaluation is the same. It's just taking them to the next step, which is understanding the sport component. You've all heard, I'm sure, of Cheryl Calder. I'm a concussion vestibular rehab physio as well. My brother, again, life experiences. My brother is epileptic from a concussion. And I get very annoyed when it's associated only with rugby, because at the moment I've got a surfer, I've got a cricketer, and I've got 2 mountain bikers that are actually suffering with severe concussions. And Cheryl Calder, she might be known for all her elite teamwork, but she's a crucial part of my post-concussion rehabilitation. So you've got to connect with people. You've got to be passion-driven, and it's amazing. Your life experiences should drive you down a path that before you know it, you're doing exactly what you love to do. I wake up every day excited about meeting people and connecting with the doctors that I work with, and the bios and the OTs and the I'm excited about seeing my patients because no two patients are the same in my eyes, and they present maybe the same condition but differently, or maybe they present the same but have different conditions. And it's a puzzle piece. It's forever changing. It's never the same puzzle. And so my best advice to you is, because I didn't have a PowerPoint presentation, one, because my pictures, I think I'd have to try and dig out some box in my parents' garage, to be completely honest. There are no fancy photo pictures on a stream on a phone from my era, but also because my journey's been so long, and it's never ending, and it's a continuum, and I know that it'll never stop. And I longed for connection, even though I have my own physio practice and not a multidisciplinary team on site. I make sure that with every patient that comes in, that I have a doctor associated with that patient, and if need be, it's the podiatrist, and if need be, it's a bio. So I love connecting with people. I love seeing different people and communicating in my practice. And also I love movement. So with that, I'm active. I played a fair amount of sports as well myself, as well as the dancing background, as you know. And so, yeah, I would say use everything that you've been exposed to. See how it is that you're going to make that your job, so that you're excited about waking up. Don't let negative no's stop you in your tracks. There are other ways around. We often, and I'm a perfect example of, it wasn't a straight road. I'm not your high academic. I learn by doing. I learn by trying. I'm not scared to say I don't know. I'm not scared to refer. I'm not scared to go and sit in with a specialist and see how they assess and work with doctors and communicate all the different options. But yeah, it doesn't matter where you study. It matters the connections you make along the way, and that you are passion driven. So I hope that you don't feel tied down to one thing. I hope that you don't feel you have to limit the way that you are, that you have to box yourself. Make sure that you use every skill that you've learned in your life toolbox along the way to decide where you end up. And that could be 5 years from now, it could be 25 years from now, it could be 30 years from now. But as long as you're passion driven and connect with people along the way, you'll find your life rather exciting. So yeah, that's all I have to say, and I'll hand over.
Thank you so much, TJ, for sharing your experience and reminding us that you can achieve whatever you put your mind to. It was so great to see how you incorporated your work experience with your traveling, especially around England. Thank you for sharing how you overcame many obstacles throughout your career and how important connections are throughout your life. I think your story, along with Bronwyn's and Carol's, helps so much to cement the importance of following your passion. So thank you. We're now going to move on to just a quick question answer series. So we've got about 2 questions per speaker. So starting with Bronwyn, so have you had any experience with NHS? What is it like, and any thoughts compared to South Africa?
So that's a really brilliant question. I have only in the last 6 months started working in the NHS because of COVID. All the exams to convert our degrees were delayed. And it takes I think my first experience is that it takes a very long time to get registered in the UK as a doctor. People think that they can do it in less than 6 months, and that's not possible. So I would say budget a lot of time, at least 1.5 years, I would say. The NHS is a really amazing organization, and it's so interesting to work in, but it's so different in so many ways. So our patient records are all online, and they have a very old, very clunky online like electronic record system that they use in the hospital I work at. So it takes me so long to do simple things, and sometimes I just wish for a pen and paper that I could write down 1 meter saline stat, because it takes me like 15 minutes to do that sometimes on the system. And the patient population is very different from what I was used to in South Africa. So on a normal general medicine call, I will see the average age of my patients is about 85, I would say. There might be a young patient who's about 60, and the oldest patient I have seen so far is about 102. And so it's just a completely different demographic than I'm used to. Their veins are much more difficult to drip. So very different patient population, but the training is still very similar, and the doctors are very similar to the ones that we work with in South Africa. They just know different things because they treat different things and they see less trauma. And so far, it's been a mixed bag. I've enjoyed it. I miss working in South Africa. I think that's what I feel comfortable doing in and what I spend all my time doing. But it's a great model to know that anyone can get the best treatment that they need without ever having to worry about payment. So that's awesome too.
Thank you so much. So next up is Carol. So was there anything specific you were required to do in order to apply for your registrar position after being on a cruise ship for so many years? Any part ones or any exams that you had to do?
Okay, so I was super lucky. At the time that I applied for the Reg program, there were more posts going than there were applicants. So I was really lucky. I didn't have part ones, I didn't have a DPEC, and I had been on a cruise ship. So if I could see people applying now, I'm not convinced that I would have offered myself a registrar position, if that makes sense. So I'm now used to sitting on the panel where we have registrars. And typically now to get into a reg program, you would need to have a couple of years experience in whatever you want to do. And for emergency medicine, you would want your primaries and your DPEC. But if you were to go off onto cruise ships, you could do that while you're on a ship. So provided you're home to write the exams, you could easily study while you're on board. And the advantage is that universities, so now I've been at Helen Joseph, so in Joburg, I know the Wits circuit better than UCT. But Wits was considering the time that people spent on cruise ships as emergency medicine time. So they've got a point scoring system, so you get points for your DPEC, points for your primaries, and points for however many years you've done emergency medicine as an MO. And they would count your time in South Africa in an ED department, and they would count your time on ships because they've realized that what people were doing on ships basically was exactly the same, obviously not quite as intense as on land, but same patients. So they were considering that time ED time. So it counted to people's advantage, which I think is a really great change that now people are recognizing that working on cruise ships actually is useful and is beneficial to people when they're applying for a reg post.
Thank you so much. So on to TJ. So how does someone get involved in medical teams for sports teams?
So, yeah, that's quite an interesting thing because I think, again, it's going to come down to connections. I mean, how did I get my first job with Western Province Cricket? Well, it was because someone knew me along the way as studying as a student. I actually was in second year when I did that World Longboard tournament in PE with Helen Milson. And I mean, it was unbeknownst to me that she had put my name forward for the Western Province Cricket job. But the connection was made, and I think that's what I know Carolyn has said it, I know that Bronwyn said it, you can't get so bogged down in the processes and have your head down with blinkers on it, but like those horses that you see with their blinkers, because without you are actually meeting some of really influential people, and maybe not at the time that you are particularly working with them, but because you don't know what they're doing behind the scenes and their connections they're making. So the thing is that you need to be connecting. Everyone that you are working with in your environment is important, and they are connecting with other people that are important. And it was really unbeknownst to me that I got that job. And then the one ricocheted onto the next one, and it ricocheted onto the next one. You can only get South African I mean, colours is not really the right word, but selected for those teams if you're working within the franchises. So, I mean, it is always like everything, starting at the bottom and working your way up. There's no quick route. And I think once you've done one national team, then another national team becomes an option, and it just, like I say, it's a snowball effect. And we really can't, I mean, we've all said it, but you cannot negate the importance of relationships. Beyond yourself and friends, but within your working environment, it's you can't put monetary value to it, and it really was one huge stepping stone that stepped me up in the path where I am today. So that's the way I'd say is you literally go and spend time, even if I've done a lot of non-gratis work, and again, those things also, you don't know who you meet along the way with that sort of stuff as well. And but go and spend time at the side of a rugby field. Ask a physio who does, rugby teams, club rugby teams, and go and spend time there, because it's only if you're passionate about it. I mean, that's the other thing, is some people don't want to be on call 24/7. I mean, I'm dealing now, I've got my phone ringing, I've got a player sitting in England playing the hundreds tournament, and it's not, it sounds glamorous, but it's definitely not glamorous work, because you've got to be on call 24/7 with different time zones, with athletes all around the world. But again, down the line, I believe what goes around comes around. What you put in is what you're going to get out. It's all very cliche, but it really, really does. It's slow. It's a slow paving surface that happens just ahead of you as you're following your path down whatever passionate drive you want to go, like Carolyn's picture, where you kind of hit that crossroads. So which way do I want to go? So I would say connect. That's going to be the best way to say it.
Perfect. Thank you so much for that answer. So back to Bronwyn, how can students get more involved in research?
So there are probably 100 different ways to do it, and I'll just suggest a few that help me. So the first is that as med students, we're really lucky that we have a research rotation in our second year. And I mean, our second year is really early, so I had absolutely no idea what I wanted to do in second year. The only idea of what a doctor was in my mind was our family GP, because he was the only doctor I knew. But I knew I really wanted to get hands-on experience, and so our friend said that Prof. Gaji and Ursula are really good supervisors, and I was like, that sounds great. They're going to have me in the hospital. I want to see what this doctor thing is about. I'm tired of studying physics and chemistry. And so I just picked a project that gave me a lot of experience, and I met them, and I was really lucky. But I know a lot of friends who pick projects in like cardiology or pediatrics that they didn't enjoy, but they still learned something. And then from meeting people doing that project, they said, thanks so much for your time. Do you know someone who is doing infectious disease or vaccine research? And all of the UCT academics know each other. All of them know what they're involved in. You just need to ask. And another great way is being involved in societies like SHAWCO and SurgSoc, because when you're organizing talks, you're meeting the academics. You can, in my day, SurgSoc was managed a lot with Prof. Khan, and he always knew which surgeon was doing which thing and who could organize for you to go into different surgeries. And so I would really just say, honestly, ask everyone that you come across. If you are interested in cardiology, when you have a cardiology tutorial, just ask. They may not want students around, but they'll probably know someone who has something to do. And also start off really humble. So don't expect that your first project will mean that you're a first author on a paper and then you're set for research for life. I did thousands of spreadsheets where I was just coding yes equals 1, no equals 2 for hours and hours on end. But it taught me patience, and it taught me diligence, and it taught me that I need to be really mindful about making sure that you have good quality research and good quality data. And after years and years of that, I eventually started to move up. And even now as a PhD student, I do hours of mindless work, but it all builds up. And so honestly take what you can get and move up from there.
Thanks so much. Then on to Carol. So how does Malta healthcare differ from South African healthcare?
Okay, so it is actually very different. Two things that are different. I find that at the moment I'm working in a private hospital. So I think even if I was in private in South Africa, that would have been different to Helen Joseph. So a couple of the basics. I work in a hospital with a cafeteria, and in the bathrooms, there's toilet paper and the water runs and there's soap and there's hand towel. It's really something quite different to the average government hospital. So private is very different in terms of the working environment and the patients you see. In terms of Malta versus South Africa, there's no trauma, next to no trauma. I keep waiting for someone to get stabbed or shot. I keep hoping someone will get stabbed or shot, and no one has been. There's no major car accidents. The island's tiny. You can't get up enough speed going from one side to the other. And the medicine is old people medicine. I think exactly what Bronwyn was saying. There's just such a huge geriatric population that my average patient I admit, so I'm a private hospital, the average patient that I admit is going to be 80 plus with pneumonia, or they're going to be 20 and needing a boob job. So that's the kind of bizarre aspect of private medicine. So it's very different to what I was doing in South Africa, and I really enjoy it. But, and I think a lot of people, if you've been involved in SHAWCO, will have the same feeling. I think that I offered more to my community working in Joburg in Helen Joseph. So I'm enjoying private medicine because it's such a nice change, but I can't see myself doing it long term because I think that there are people who need doctors, and I struggle with the concept that you have to pay to see a doctor. You have to pay for the care that you get, which I think is a major advantage of the NHS in the UK, where care is provided. And South Africa, for all its problems, and there are plenty of problems, if you have an issue and you get taken to a government hospital, you will get seen by a decent doctor and you will get cared for. If you can pay absolutely nothing, you're not going to be left stranded. And I realize that there are massive issues with government hospitals, but you're not going to be left lying on the side of the road. And I don't really like working in a private setting where people have to pay to see me, just because that doesn't sit nicely with me. So that's a little bit different, but I really like the fact that when I wash my hands, there's soap and a hand towel. So there are definitely some advantages to it.
Thank you so much for that answer. On to TJ. So what is it like to travel with sports teams?
So, look, you obviously get to travel the world, which, like Caroline will say, is the great side of it. But then, of course, you've also, my job gets last on the list. So I don't know if anyone's ever traveled as an athlete, but you know, half the problem the athletes have is when they come back home, now the girlfriend wants to do the movies and all the friends want to see you and all that. And they've actually been living on a rigid timetable from the moment they left. You know, there's a manager that books your flights. There's a manager that, you know, there's a luggage guy that will do the luggage. And then you're told, like, now definitely you got all the COVID testing, and that's a whole nother scenario. I haven't traveled in that time, but I just know because I've got a few friends sitting in Tokyo and athletes in Tokyo, and it's a nightmare. It's wonderful getting to travel the world and to do what I love. That's the first answer. The second is, unfortunately, like when I was in India, the coach's job and what timetable he wants, that comes first. Then there's going to be the captain and what he wants done. Then the guys also want to eat when they want to eat. And I found that I'm treating at like 6 in the morning, strapping at 6:30 and still working at 1 o'clock in the morning, whether some of the guys are coming after supper to treat. You got to be prepared to do that. That's just, it is what it is. I also then got cleverer at teaching the guys that didn't have to practice. You know, you start getting better at your communication skills with the coach and saying, well, actually, so-and-so, in all fairness, is not going to achieve anything practicing. So can I treat him at practice? So then my treatment room kind of came to the side of the nets, and then I'm treating on the side of the field. And then that oak, when he's finished what he needs to do, I'm going to do his rehab so I don't have to try and find time later. So time management becomes quite clever. In the 4 months that I was in India, I only got 1 day off. And that's where I went to go and see the Taj Mahal. So I love everybody, and I know they literally didn't want to even hear it from you when I was doing physio. If you mentioned the word sports physio, they didn't want to know that that's what you were going to do. Then, like Carolyn said, there's a community that needs you. I want to say to you that I agree totally, but there is also a community of sports athletes out there. And that doesn't stop you getting involved with that. And I still do it, even though my practice is at Villages Rugby Club and I only see, you know, technically people that pay. I do a lot of behind the scenes work, and I have the same players come to my practice and treat it as if they were paying, but give them exactly the same experience and the same education. You can still add value, even if you're in private practice per se. So traveling's wonderful, but your time's not your time. That's what you do need to realize. And there's a lot of